Hello, good afternoon, everyone. I think we're just about ready to start. We've almost got a full deck, so I think we'll get underway. Thank you for joining us at this official WHA side event, Immunizing Across the Life course, supporting healthy aging, NCD management and system resilience. I'm Shuli Ghosh. I'm delighted to be facilitating today's discussion, co-organised by the International Federation of Pharmaceutical Manufacturers and Associations, the Global Allergies and Airways Patient Platform, and the International Federation on Aging. So I'd like to start by inviting you to just pause for a moment and reconsider how we think about prevention. Not prevention as an abstract concept, but as a lived practice embedded in how health systems are designed, financed, and delivered across every stage of life. Because the reality is that millions of people are living longer and with more chronic conditions. And that demographic shift is putting new kinds of pressure on health systems. Prevention has become a core strategy for strengthening population health and resilience, and adult immunization is a critical part of that strategy. And yet, despite decades of progress, when we talk about immunization, we still tend to think of it primarily as being about childhood. But today's conversation is about what happens when we extend that thinking and ask what it would mean to protect people not only in childhood, but throughout their lives, including people living with chronic conditions and older adults. So this is exactly what we're going to explore today, how life course immunization, including adult immunization, can be better integrated into routine care, and how prevention can be translated from principle into practice in aging societies. So I will introduce our speakers properly in just a moment, and we will also be hearing from Gregor Snedden, Secretary General of the IFA. But first, to open the conversation, I'm very pleased to invite David Reddy, Director General of the IFPMA.
Okay, Shuli, thank you very much. And it's a pleasure to be here today with colleagues from the global health community of Geneva. So, excellencies, distinguished guests, colleagues, and on behalf of GAAPP, IFA, and IFPMA, I'd like to warmly welcome you. So, we're about the closing of the World Health Assembly, and this session is to highlight the interconnected challenge of aging populations, rising non-communicable disease incidences, health system pressures, but also preparedness in case of the types of health shocks with outbreaks of diseases, etc. What we'll also focus on is an opportunity, and that is to use innovation-driven prevention, especially adult immunization, and the need to prioritize that. So the session will highlight, first of all, by focusing on vaccination, the ability of vaccines to protect at every stage of life, from childhood to older age, how it can strengthen health systems and economies and build more resilient societies, and where pharmaceutical innovation fits into this wider context of prevention, earlier intervention, stabilization of chronic conditions, and lasting changes in disease trajectories. So I'll start with the impact of vaccines, and just personally, during the course of this year, I've had 3 vaccinations, and my primary healthcare provider made sure I got my COVID shot, my influenza shot, and then because I run, he made sure I got one for tick-borne encephalitis. So it's looking after me my stage of life and my stage of activity. And I think this is how we need to be looking at the challenges that face us. We know that childhood immunization is foundational, but adult and older people's preventive care is often fragmented or undervalued. And as populations age, chronic disease burden grows, we know that, and the gap becomes more critical. Infections in non-communicable disease patients, older adults, can destabilize the individuals concerned. They can interrupt care, they can accelerate decline and drive avoidable hospitalizations. One of the ways we need to look at this then is through system solutions. Immunization should not be a standalone program. Vaccines are simple, they're cost-effective tools for health systems, and it's essential that adult immunization is embedded in primary care in the way I was just talking about in my own relationship with my primary care physician, as part of NCD management. And so we can shift from really what is a crisis situation to continuity of care and positively impacting continuity of care. This will reduce seasonal surges, it'll stabilize hospital demand, and it will preserve workforce capacity. And this will have a positive economic impact on society. Now, the economic dimension I wanted to bring in now in a little more detail. Vaccination, primary prevention can keep people healthier, working longer, and independent in the latter stages of their life. And we call this the silver dividend. There was a great article in the Financial Times about this recently that was really focusing on the increasing costs in Western society associating with an aging population and the benefits to GDP of keeping those people productive for longer. It supports productivity, protects labour force participation, and reduces economic disruptions. You get fewer hospitalisation, less pressure on public spending, and it supports households, employers, and public finances. The real evidence for this can be summed up in one figure, and that is that adult vaccination delivers a strong return on investment, up to 19-fold the initial investment. That's a tremendous economic return. But there are risks on the flip side of this to underinvestment. The financial risk is higher healthcare costs, longer-term costs, productivity losses, exposure to unplanned expenditure during illness, during surges and outbreaks to society. And just a reflection on this also, when I was working for one of the pharmaceutical companies during the H1N1 outbreak and was managing an antiviral stockpile, there was one country in Eastern Europe that seemed to require a disproportionate amount of that. It was about the underlying health of the population. If we have healthy populations, they're far more resilient. From a policy perspective, the key question is, can we afford not to invest in prevention at this time? And that brings us to another topic that has been significant at this World Health Assembly, and that is health security. That investing in vaccination helps build preparedness before a crisis, so strong routine immunization and sustained innovation together constitute the foundation for effective responses when crises do occur. So immunization is both a daily tool, but it's also key to preparedness for outbreaks and for future disruption. So in closing, I think the evidence is really clear. Vaccination has enormous benefit. We need to focus on unlocking the full potential of vaccination in aging populations and what are pressured health systems that are facing increasing risk. So my appreciation to all of the panelists. Looking forward to the discussion today and handing back to Shirley.
David, thank you very much. Yes, I mean, as you've mentioned, health security preparedness, one of the overarching themes that we've heard a lot about at this year's WHA, and all the evidence shows that life course immunisation can play a vital role in that by reducing health system burdens, reinforcing economic and social resilience. And yet, despite that potential, adult immunisation is still not fully integrated into how we design and deliver and finance care for ageing populations. So how do we change that? How do we embed immunisation within primary healthcare and position prevention as a core strategic investment? Well, those are some of the burning questions that our panel will be discussing, and they all bring with them decades of experience, and they will all be taking questions as well after the discussion. So let me introduce them to you now, starting from my immediate left. Riley Sanders, Head of Government Relations and Public Affairs at the Global Allergy and Airways Patient Platform GAAPP. Dr. Yuka Sumi, Medical Officer, Department of Advancing Life Course Health and Reproduction at the WHO. Manuel Vegan, Head of International Relations at IMSERSO, that's the National Institute for the Elderly and Social Services, at Spain's Ministry of Social Rights, Consumer Affairs and 2030 Agenda. Professor Lotte Stuyten, Deputy Chief Executive at the Office of Health Economics. And we are expecting Professor Vernon Lee, Chief Executive Officer of the Communicable Diseases Agency in Singapore, and I think he will probably come in partway through the discussion. So let's kick us off, team. Let's have a look at the challenges and the strategies and what it could look like. And Riley, let me start with you. You engage with people living with NCDs. Respiratory infections have a huge impact. What does they mean in practice for disease management and longer-term health outcomes?
Thank you so much. So when we talk about people living with non-communicable diseases, adult asthma and COPD, that experience really varies a lot between high and middle income countries and low and middle income countries. In high and middle income countries, we have a large undiagnosed population living with COPD that do not know it. We also have a large population of people who are living with asthma who think their asthma is in control when really it is not in control. When a respiratory virus or illness impacts them, they're at a heightened risk of an exacerbation or a flare-up. For a COPD patient, this means causing lasting permanent harm, as well as an increased rate of mortality and readmission within the next year. These are incidences that can be avoided through immunization, and we see this play out throughout the healthcare system, especially in countries with high seasonal disease infectious periods, where infectious periods break out in community and then they're followed months later by exacerbations inside hospitals of people living with COPD. If we're able to promote vaccines inside this care treatment, we're able to avoid this. People living with COPD are doing everything that they can to manage their condition. They have action plans, they're monitoring air quality, they know their triggers, they are active and not vaccine hesitant at all. What they're lacking is information and access, and oftentimes reimbursement criteria don't match up with the guidelines that are set forth for them. They have to navigate often a fragmented system, navigate different reimbursement criteria, go to different settings. And this isn't the same that's done in other population groups that have it much better laid out for them. In low and middle income countries, COPD and asthma is often only taken care of inside the hospital at the point of exacerbation. There is no primary care access for inhaled therapies. It's just now that we're starting to see new models of care develop there. So that makes reimbursement and policy a lot more difficult to navigate when we think about how do we get the medicine into people who don't know, who have COPD and don't know it yet. But it is still a worthwhile endeavor that we need to try to fix.
Yeah, because life course immunization, as David has already mentioned, it doesn't just improve lives, although that is a big part of why you'd want to do it, but it substantially reduces the shock of impact on global health burdens.
Absolutely. And these people are the most active in their care. If anyone's ever seen an asthma or COPD action plan, they're monitoring everything. They have a prescription for antibiotics, antivirals. They're self-diagnosing and doing everything they can to stay out of hospital. This is something very small that governments could do to help them in this fight.
Okay, and we'll talk about pathways a little later on. Thank you, Riley. Yuka, so Riley has described, how preventable infectious diseases have that impact on individuals and health systems. So looking ahead to 2030 and beyond, how does the WHO see care systems needing to evolve to support both aging populations and people living with NCDs?
Yeah, thank you very much, Shuri, for the very important question. Everybody has a personal history or story to tell about older people and aging, right? You have your parents, you have your grandparents, and yourself, ourselves, are aging. By 2030, 1 out of 6 people in the world will be aged 60 years and over, which is celebration. We live longer, but are we living longer and healthier? As Riley actually explained about the difference between low and middle income countries and high income countries, 2/3 of the older people in 2050 will be living in low and middle income countries. So looking ahead to 2030 and beyond, WHO sees a fundamental shift from episodic, acute, and disease-focused care to continuous, person-centered, and integrated care. This is really critical to advance quality of health services towards universal health coverage in aging societies. In this shift, as Dr. David actually mentioned, primary health care is the backbone of the UHC. Not only as the entry point to the care, but also the platform for delivering integrated and person-centered care across the continuum, from prevention to the promotion to the treatment and rehabilitation palliative care. This creates more equitable care systems by linking primary care with essential public health functions, which include immunization, and fostering age-friendly environments, promoting self-care and self-management, empowering older person and the community, and multi-sectorial action. Health is not only health sector. Actually, health needs to be taken care of by multi-sectors. And this requires a shift from reactive to proactive. As the UN Decade of Healthy Aging, 2021 to 2030, now the year of 2026, so the middle point, really emphasizing the goal is to maintain the functional ability by preserving any physical and mental capacity of older people and preventing the decline, and not only treating diseases, but also with the enabling environment. So in practice, this means integrated care pathways that support older person or people over time throughout the life course across any settings.
So an entire continuum of care. In an ideal world, Yuka, how would that look? A well-functioning continuum of care with immunizations integrated along the way?
Yes. Dr. David actually already mentioned around fragmentation of care. But in the ideal world, well-functioning continuum care is the one that is person-centered, understanding person's values, preferences, and goals, and coordinated and continuous across the life course. It spans the full spectrum of services, prevention, promotion, treatment, rehabilitation, palliative care to the long-term care and palliative long-term care, and then follow the person across the settings rather than expecting the person to navigate complex systems. From a WHO perspective, the continuum is anchored in primary health care and delivered through multidisciplinary team. We are not talking about only doctors or nurses, but the multidisciplinary teams, pharmacists to the social care worker, to the community health worker, to the physiotherapist. Everybody needs to work together to have a personalized care plan, and then strong link to the community-based services. Immunization should be part of the continuum, not a separate vertical program, and it should be integrated into routine services for older people and people living with chronic conditions. The COVID-19 pandemic told us actually clearly that the older people are too often missed when services are not designed around their needs. And there is an ageism that actually really accelerate the discrepancy between the service needed and the service provided. So it is really critical to more equitable, accessible, and responsible while creating demand and behavior change of older person, him or herself, with the accurate, accessible, right information to older people.
Thank you, Yuka. I want to come to you, Manuel, because I know that Spain strongly promotes lifelong immunization. So tell us what role prevention, adult immunization has played in helping to promote a healthier population in Spain, and how is that impacting on hospitals and the health system?
Thank you so much for the question. First of all, is that aging population and demographic shift is certainly depicting a huge pressure for hospitals and care services. So as the WHO said, we are living longer, and the national government has to be conscious to enact new laws and new programs for more immunization and also for prevention. That is the cornerstone for health system for Spain. Health system prevention measures are certainly a priority. So this is essential for supporting healthy aging. And in Spain, we have enacted a new prevention and promotion of health law. And we have also enacted in 2024 a strategy for deinstitutionalization to have a community-based and life course approach for long-term care of persons in a situation of dependency. It's essential for these persons in a situation of dependency, these persons who need long-term care, to have a person-centered approach from governments with new principles, new rights, and new services. That's why Spain has enacted, as I said, this new strategy on the institutionalization, and we are also reforming the law on personal autonomy and care for persons in a situation of dependency. This law enshrines new forms of prevention, new programs for immunization, and also several changes for health system in Spain. It creates new programs for vaccinations, and also it creates new stands for more information about, for example, the antibiotics consumption. But as I was saying, it creates new principles for long-term care, including freedom of choice, desires, preferences, self-determination, because it's essential that older persons has this freedom of choice, this self-determination, and also a personalization of care and support according to older persons' will. This is essential to protect and foster this older person's will in prevention of health.
That sounds amazing, and it's making me want to actually retire to Spain. So thank you for that. I know that you were talking about the schedule of immunization. So if I understand it correctly, there are specific vaccines for residents over the age of 65. For example, the pneumococcal vaccine, I'll pronounce that correctly at some point, and shingles is also included. So you've got some very specific immunization programs. What have been the main challenges then in getting that off the ground?
The new law of prevention and promotion of health has created new vaccination programs for and new timetables for older persons that creates a more specific calendar for immunization, because it's essential to grant from the government, from the National Institute, this prevention and this immunization. It's a program that has been designed from Ministry of Health with collaboration with our Ministry of Consumer Affairs, because in fact we wanted to enact a program with vision, healthy vision, but also social vision, because in Spain we are enacting programs for not only a healthy aging, but also active aging. So we are promoting active and healthy aging, and this is also very related with these new principles of the reform of long-term care law, with more self-determination, personalization of care, more information for older persons, also regarding immunization and prevention.
How do you decide what immunizations need to be included on the schedule?
This is a decision that is coordinated by the Ministry of Health, but
Right.
of course with hospitals and care services, because in fact is where older persons are, or when they have to go to hospitals, and hospitals has a lot of decision-making power in this process in Spain.
And what's the main impact you've seen? Obviously, very happy and healthy seniors wandering around Spain, but health-wise, what's the impact you've seen?
Yeah, well, of course, apart from the satisfaction of older persons, but it's certainly according to the data of SAT, that is the System of Autonomy and Care in Spain for older persons. They have established that the prevention has improved 97% with
Wow.
these measures. So the new program is very successful. And also it's very important to link this new program with the ideas of the institutionalization for these persons. The institutionalization, it means that not to eliminate institutions, but it means that older persons should live the more similar to their homes, because according to the Spanish data, 89% of older persons, if you ask them, they would prefer to live
be at home. Yeah. Yeah, that's great. I'll come back to you and talk to you more about that, because I think it's a great example of what a country can do. And Lottie, I'm sure you agree that Spain shows what's possible. However, the reality is that, you know, for a lot of countries, budget is a challenge. So how do we reframe then the cost of prevention?
Yeah, and indeed, Manuel told it very well. We basically see what good looks like. We have data. Dr. Reddy already mentioned the 19-to-1 return on investment. So I would like to start from that statistic to sort of then tell how we can reframe how we position vaccination and prevention. So the analysis that we did at the Office of Health Economics that resulted in the 19-to-1 return on investment found indeed that when you quantify the value of vaccination, adult vaccination, from a broader socioeconomic lens, instead of the typical more narrow health system focused lens, which is what most healthcare decision makers are used to, and that's what they know, then you find indeed that this value is so high as we found it to be. Of course, not every vaccination program will return exactly 19-to-1 return on investment. I think that probably speaks for itself. But the main message is that all the programs that we studied in all the countries more than cleared the break-even point. So this is not a marginal issue. This is a very, very consistent picture for very different vaccination programs in 10 very different countries. I think the issue with most of the studies that we see around is that they have a very important blind spot. And that is, they typically focus, as I said, on the healthcare system perspective. So we know everything about how many hospitalizations are avoided, how many GP appointments, what the cost impact to the healthcare system is, but we know very little what this broader socioeconomic value is. So what we did after we analyzed the 19-to-1, because then you get the question, who gets what part of the 19 right? And this is where you have to start a reframing of the data to make sure you reach the right stakeholders. So we looked which part of that 19, so to say, falls on the healthcare system and which part falls on the wider society. And we did this analysis across 4 countries, but I just want to highlight the data for the UK. For the UK, we found that for every pound of value generated to the healthcare system, 8 pounds of value were generated to the wider society. So you see that by far the largest share of value of vaccination falls to the broader society, while the value within the healthcare system is also tremendously high. So if we want to sort of reframe prevention and vaccination in a way that really captures the value, we have to be really clear about where that value is generated. Also important to say that sort of return on investment was really driven by the working age population and all the populations in terms of productivity not only labor productivity, also when you're retired, you can be productive. You volunteer, you do things, you maybe look after your grandchildren. So all of that is factored in. I think that is really important to reframe how vaccination can be a sort of economic growth and sustainability engine for societies more broadly.
Yes, because we have to look at it holistically. It's not just healthcare costs or patient benefits, it's caregiver burden, it's productivity, it's health systems. You mentioned the return on investment there, Lottie, and I wonder, how do we use that data? Because that's really compelling data. How do we use that data to make prevention a strategic investment for policymakers, especially in low resource settings where there are so many competing priorities?
So what is really interesting when we talk about this work, particularly for lower income settings, sometimes I found that these data resonate even better with them than they do in higher income settings, because they understand firsthand how important healthy populations are, how important it is that people can remain active within the labor force and outside of that. So intuitively, there's this really good understanding. The challenge, however, is when we look at budgets, vaccination is typically a line item that is similar to, for example, line items around hospital supplies, salaries, etc. These are recurrent expenditures, and that means as soon as there's pressure on the budgets, these are the most easy to cut out. And that's a big risk what we see for vaccination. These are very much at risk for short cycle decisions, whereas they should be more akin to education and other skills building, be seen as a medium-term investment and a medium-term budget line item. So this is really tricky because this, of course, puts the budget at a significant risk. And what we need for vaccination is to have sustainable ongoing funding. If you turn on the tap and you turn it off for COVID vaccination, for example, that is going to give you much less great results. And it also doesn't help for the population to understand, should I get this vaccine? I needed it last year, but now it's not available anymore. And now it's only for like a different age group. And now people at risk are included and now they aren't. I mean, that is very confusing for everyone. And that's not the way to communicate the sort of long-term, but also shorter-term value of vaccination.
Lottie, thank you. So let's talk a little bit then, panel, about how we make this routine. What actionable levers can make the difference in integrating life course immunisation into our systems? And Riley, you were talking about the importance of immunisation for people who suffer, who are at risk of infectious respiratory diseases. If adult immunisation were truly integrated into NCD care, what does that look like? What would feel differently for patients? Where does it show up in the pathway?
That's a good question. And I think when we look at it, it always has to start with reimbursement criteria. When we look at who is covered and who is not, we have to take that holistic approach to understand that there are several factors that should be brought into that beyond just age for it. As I said, people living with asthma or COPD are at high risk of both developing the disease or illness, and it also extends or worsens their chronic condition. Also, governments need to see themselves as an active player in the health promotion cycle. It's not enough just to cover it. It needs to be spread out and disseminated and educated in the populations. Government should look at vaccine waste as a failure of health promotion, not as a failure of individual choice or a choice. When we're talking about how that integrates into care, for NCDs, especially asthma and COPD, integrated care is still a high issue where many high-income countries struggle with. We have several models of care that are quite strong, but they're not available everywhere in the country, and they are not well utilized or embedded. I think when we look at some examples that are doing it well, if we look at transplants, organ transplant programs, they do immunization extremely well. Their reimbursement criteria is very clear. Patients in that program get a text or a call reminding them that this is the time, this is why you should consider this vaccine. It is embedded there. For respiratory, obviously, it's a larger population group, so we are going to need to look interdisciplinary. It means every time a pharmacist is refilling an inhaler, They're having a conversation. Every time you talk to your GP, they're having a conversation. When you have a meeting with a certified respiratory educator, you're making a vaccine plan. You're embedding it into your action plans. It becomes part of your normal care program. That's what it's going to have to take, is alignment of political will, reimbursement criteria, interdisciplinary, and integrated care.
You've mentioned knowledge and education a couple of times now. Who is it that doesn't have the knowledge and education? Is it the patients themselves, or is it the primary caregiver? Or is it both?
It's both. Primary caregivers are excellent, but they're juggling a million different things. Expecting them to know the latest vaccine and how that impacts every different person or patient in their clinic that has a chronic disease is a high burden to have, as well as being equipped to have that conversation and answer questions is a lot.
But we saw from Spain that it's possible. So it actually just takes the political will to think, right, that is what we're going to do.
Absolutely.
Yeah. I mean, and it's so simple that you were saying, for example, pharmacists could have that conversation. So it could happen at all stages if it was there as an option.
Yeah.
Thank you, Riley. Yuka, the vision for heading to 2030 and adult immunization, what are the priority shifts that countries can make, particularly at primary and community care level, to support older adults and people living with NCDs over the next decade?
Riley already mentioned the importance of the universal health coverage. So reimbursement means actually the quality health services, including promotion and vaccination, will be provided at the right timing and everywhere. That is the important basic starting point. But oftentimes prevention and health promotion is left behind because our medical health system is treating diseases. That is kind of the first format. And then prevention, we need to really shift to the prevention and promotion. And then we recognize the difficulty for the accessibility for the healthcare facilities, especially for the people, because of the distance, because of the complicated appointment, because of the cost, especially for those who are living in rural areas, accessibility and availability of service becomes a bit of a tricky part. So we are really promoting to bring services where older person lives. That might actually, through the age-friendly environment, maybe there is a bus app freely available to bring the older person to the health facility, or using the community trusted platform. It can be actually market. It can be religious places where older person come often and they use as a vaccination or a health promotion actually venue. And that is really well taken in. And I see that actually there are different good examples and case studies, especially from around middle-income countries. And then second is I really would like to highlight really addressing the ageism in the service design and delivery. For example, often systems are not designed to adapt to the older person's needs. Clinical trials often actually do the study except older people. That is exclusion criteria, for example. National Immunization Technical Advisory Groups, NITAC, does not include the experts on the older people's health.
Oh, really?
Some countries actually really focusing on pediatricians. And pediatric
so it's still focused towards
younger age.
Children, yeah.
And we need both. I'm not ignoring the child immunization, but we need both. And then finally, really the skills and the competency of the healthcare workers, they need to actually be trained on how to actually bring the vaccination as a part of the health and lifestyle advice, how to promote, to maintain the physical and mental capacities so that they can be independent as much as possible, how we can early identify these risk factors, who has the risk factors to develop the non-communicable diseases and infectious diseases, to identify, to support them as needed. So this requires a lot of the competencies, so we need to invest on the workforce.
But can I just ask you, because we have had a political declaration on NCDs, and it does talk about prevention. So surely some of these commitments are now feeding through to countries that have signed up to that.
Yes, it's gradually happening. So there is a conversation on, for example, tobacco cessation or healthier food style, or the alcohol decrease of the alcohol consumption. And is the vaccination treated as much as they do? I don't not.
Well, the political declaration didn't specifically mention adult immunization, so
we need to bring at the same page as other prevention.
Yeah.
Thank you.
Good point. Thank you, Yuka. Manuel, I mean, I'm absolutely fascinating to hear how you've integrated both healthier living for the elderly population and immunization into society in Spain. So I guess the question is, what lessons should other countries and other health systems be learning from Spain?
Well, it's not easy. It's a difficult task to integrate these immunization and prevention policies with healthy aging public policies. It's not an easy task. And maybe the lessons that other countries could learn from Spain are not only the good examples or the good practices of our country, but also what not to do, that you have to set good fundings for these policies. Fundings are essential, of course. Also to integrate this life course and center person approach is very, very important. And also now in Spain, we are very conscious of the importance of health workers and caregivers. Not only the formal caregivers, but also the unpaid or informal caregivers. We are very focused now on improving these labor conditions in these areas. And I think that the principles I mentioned before of self-determination, personalization on care, and the institutionalization are the most principles and in fact rights, because we are also talking about older persons' rights. And it's important also to say that now in the Human Rights Council, we are starting to draft an international legally binding instrument, a future convention for older persons that will be probably a global challenge, but will enshrine human rights for older persons. And I think this also human rights approach is essential for immunization, for prevention, for a better health system. And I think these are the main lessons to learn.
Thank you. Thank you, Manuel. Welcome, Professor Lee. Good to see you. I'm glad you made it. I'll give you a couple of minutes to settle in and maybe come to you first, Lottie, about, when we look across countries, we're talking about budgets, we're talking about GDPs. Immunization actually accounts for a very, very small share of total health spending, despite all the evidence that it is a cost benefit. So when you're talking to policymakers, how do they explain this gap?
So yeah, again, let me just briefly illustrate this, like with how small we're talking about. So again, I'm going to use the UK because that's we were based at the moment. In the UK, spends 0.16% of GDP in 2022, that was, on all of its immunization programs, 0.16% of GDP. Now, based on the analysis that I just talked about, if we look at the value of adult vaccination programs against respiratory disease, those generate between 0.2% and 0.9% of GDP within the first year of delivery. And I think that is really critical. Also want to pick up to what Dr. Sumi said. There's lots of focus on like pediatric vaccination and also this conception that vaccination or prevention only delivers value over the long term. That like we have to pay now and it will only pay back like in the future. But for adult respiratory, but also other adult vaccinations, that is not the case. That pays back, that starts to pay back from year one, multifold, and that only grows over time. So I think that is really important. If we see, however, what's happening also in the NHS, there is a new commitment to shift to prevention, but only about 5% of the spending actually went there. And in fact, the public health grant has been cut by over 25% in real per person terms. I think the challenge is the binding restraint with all of this is not the evidence. It is really how policymakers sort of think and how they view vaccination and their understanding of this broader value, and also how we choose to assess value. Like I said in the beginning, we have a blind spot. We focus on the health system impact, and we are overlooking the broader societal impact. But another blind spot is we don't typically incorporate the value of vaccinations on other conditions, such as Riley talked about, on COPD, on heart failure, on diabetes. So we don't factor into the analysis that heart attack prevented, that COPD exacerbation that didn't happen, maybe even a delayed onset for dementia. Those data are emerging. We need confirmatory trials, of course, but there's enough data there that this is not just some hand waving. There is the start of a signal. And I think that is what we're missing currently, sort of making that shift to understanding that vaccination prevents beyond the healthcare system, but also a whole cascade of events within the healthcare system.
I mean, is there some sort of consistent factors that you see that need to be in place before countries recognise or decide whether to build preventive interventions and scale them?
Yeah, so I think actually Manuel gave a very good example there. I think this needs to be part of like a much broader strategy where we really focus on, prevention, healthy aging, etc. If that is there, then it's much easier for policymakers to sort of justify their decisions within the context of those policies. But also, as we've heard before, the focus is still very much on treating acute diseases, also chronic diseases, but we basically start to act only when a disease is present. So I think this really needs to be part of a much broader shift also in the mindset of policymakers, but also all of us as citizens and society to sort of move towards that prevention. I think that is critical to really get the political will sort of there, because we have the data, it is possible. We see examples of what good looks like. So it has to be part of this sort of broader picture, and making sure that when we talk about this, we speak to the right people. We typically mostly speak to healthcare decision makers, but of course they will maybe think about, well, the value is outside of my healthcare budget, so why would I care? So also think about employers, for example. They have a direct incentive to make sure that their people are healthy. Again, a study from my team showed that within the UK, the cost of respiratory conditions, both absenteeism and presenteeism, cost UK businesses 44 billion each year. Now, if you start to talk about those numbers, then you might get some traction to sort of move towards action.
Yeah, good point. Lottie, thank you. We were talking, you mentioned the power of good examples. Vernon Lee, a great example in Singapore. You have been instrumental in developing Singapore's national adult immunization schedule, and it's a priority in Singapore because you have a rapidly aging population. So tell us about that and how it supports national resilience.
Yeah, thank you so much. And apologies for my late arrival. There was a briefing on the Ebola outbreak and vaccines.
I can see that would take precedence, yes.
Vaccines were indeed discussed. So vaccination is extremely important, as a preventive tool. And it's really our first line of defense against various diseases. And as we know, the elderly are at greater risk for infection from various diseases and also at risk of poorer outcomes. So they are certainly a population that we are very interested in protecting. So for endemic diseases, we encourage take-up in the population, especially those who are at high risk. And this reduces their risk of morbidity, mortality, preserves our healthcare capacity, and also lowers the burden of these diseases. Now, the vaccinations that we provide for endemic diseases also helps us with novel disease threats, because they will then have cultivated a sort of a mindset that vaccines are safe and efficacious and will drive uptake during a pandemic, as we saw in Singapore during the COVID-19 pandemic, leading to a more robust protection and also resilience during a crisis. Now, implementation of a program actually requires understanding of many things, the disease and nature of a pathogen, including the circulating types and whether they are matched with vaccine and so on, the efficacy and safety of the vaccine, and that requires working with pharmaceutical manufacturers, regulators to determine that, the sentiments of the population and how they actually view different types of vaccines, and all of this information is extremely important in helping us to shape the public health objectives. For example, whether we're trying to achieve a reduction of health impact or to achieve elimination of a certain disease. And the focus of our resources to facilitate that successful implementation of whatever program. And to do this, we have also invested a lot on a robust R&D landscape and plan, and also includes a lot of social science aspects, as vaccine hesitancy is always a major hurdle to uptake. Now, if we could just talk a little bit about our national adult immunization schedule. So Singapore adopts a life course approach to immunization through both our national childhood immunization schedule and adult immunization schedule. And this aims to provide comprehensive protection across different age groups and life stages. So the adult immunization schedule, we've established it about 9 years ago to provide guidance on vaccines for persons aged 18 and above. And of course, a lot of those vaccines are targeted at the older age groups. And includes vaccinations like influenza, pneumococcal diseases, HPV, tetanus, diphtheria, pertussis group, measles, mumps, rubella, hepatitis B, varicella or chickenpox, and also shingles. So these are the vaccines that we have currently on the adult immunization schedule, and we're continually trying to look at new vaccines and if we should put that onto the recommended schedules. All of our policies are supported by enablers such as financing, accessibility, and implementation plans. So if we put something on the schedule, we have to make sure that it works and we can actually roll it out. So for example, we provide means-tested subsidies to all Singapore citizens, to all Singapore citizens recommended to receive the vaccinations. And these are available at more than 1,600 clinics across the country. So we make sure that it is accessible and is accessible at a price that people can actually acquire them.
I think that's quite an important point, because you have a lot of vaccines on that list.
Yeah.
And you mentioned earlier that it has to be something that your older population are happy and comfortable with doing. How are you selling that to them then? How are they becoming aware of it? What have you built in to make them want to be immunized?
Yeah. So 3 things that we have done. One is by having a sort of national initiative that prioritizes prevention programs. In Singapore, we call it a Healthier Singapore initiative. And this really moves care more into the population and moves it upstream to prevention rather than curative care. And this includes creating a personalized health plan, including vaccinations. So this is something that we work through the healthcare providers to really inculcate this message across all the different age groups. The other is public trust. There's a lot of misinformation, disinformation about vaccines. So the public awareness and trust are very critical in driving this vaccine uptake. And we have built this trust through various means, through messaging about many different things across many different instances, not just for vaccines. So in Singapore, there's a very high level of trust in the government and the public service. And this means that when we try to launch vaccine programs, we do get quite a bit of trust in the government in terms of having people wanting to receive those vaccines because we have recommended them. And to maintain this high level of trust, we have to be transparent, timely, and accurate in our communications, not just for vaccines, but for all health issues and also issues in other sectors. So we keep maintaining this trust with the population. And finally is public engagement. We have to really reach out to the individuals most at need through a variety of different media platforms, mass media, marketing platforms, digital advertising, social media. And for the elderly, it is usually quite tricky because they may not ascribe to a lot of these media platforms. So we have to look at things like grassroots leaders, befrienders who usually engage with them on a regular basis for their social needs. And when we run vaccination programs, we partner with them. So for example, during the COVID pandemic, we actually went on a door-to-door exercise to reach out to the elderly who are at risk. And we paired up a befriender or grassroots leader with our vaccination team. Because the elderly will be receptive to the befrienders who they already know. And after the befrienders have convinced them that the vaccine is necessary, our healthcare team is on standby to deliver the vaccine at their doorstep. Very labor intensive, but this is how we close the last mile gap. Thank you.
Thank you. I just quickly want to ask you something, Riley, because Vernon was talking about there's a high level of public trust in the Singapore government. It's not quite like that in the UK. So it's trust a massive issue in trying to get people to engage in preventative measures like this.
I think in the general population, I think that's pretty fair to say. Like I said before, though, those who are living with asthma or COPD are very, very keen for any information or any way that they can to protect their lung health. These are people who are struggling to breathe every day, whose normal behavior and normal actions are now outside of their ability to do. They're keen and they understand that anything that they can do to prevent that next exacerbation extends their life and their ability to work and function. They want to learn. They want to learn about their condition. They want to learn about how to care for it, and they will see vaccines. They do see vaccines as a crucial part of that.
Okay, that's a good thing. I'm going to come to questions from the audience in just a couple of minutes. I just want to put one final question to all my panelists. It's the same question, and panelists, if you can keep your answers to a minute or less, I would be really grateful. So the question is this: what is one change that you would prioritise in the next 12 months to successfully integrate life course immunisation into primary healthcare? And Riley, why don't we start with you?
So I think I said it before. I think governments, the one change would be is that governments have to see themselves as a vehicle and an active partner in health promotion, and vaccines have to be seen as a part of that. It's not just enough to reimburse. You have to be part of the system, working innovatively across discipline, across different health partners to deliver that.
Thank you, Riley. Yuka.
I would say involve older person and their family members in the program design and delivery. That's actually listening to their voice makes the program accessible and then acceptable and then adaptable for their needs.
Thank you very much. Manuel. Oh, Manuel's. I did it. I was so involved in what you're saying, I didn't even notice. Okay, hopefully we will get a response for him when he comes back. Let's move on to you then, Lottie. What do you think the main priority should be?
So, as an economist, I was going to say we really have to make sure that we value vaccination, adult vaccination, and also other preventative interventions from a broader societal perspective, in addition to the healthcare system lens, and really make sure that everyone understands what's in it for them and sort of build our messages on that.
Thank you, Lottie. And Vernon.
Yeah, for me, I think the most important is to get all the relevant stakeholders engaged and on our side. And that includes providers, because they have to sell that message to their the individuals, even the funders, for example, to look at cost-effective solutions and to how to get vaccines on board. The community partners that will help us to actually, interface with the people, the high-risk population, and of course the other people in the network, like the pharmaceutical manufacturers and others. I think everyone has a part to play in trying to drive home the message that vaccines are important as a source for prevention, rather than to look only at curative solutions. Thank you.
Thank you. Thank you very much indeed, panel. That was a really wide-ranging discussion. Do we have any questions from the audience? Lady at the end there.
Good afternoon. Thank you very much for this side event, shedding the light on the importance of the life course immunization. I'm Dr. Nada. I'm from the United Arab Emirates. My question is how to increase the public trust after the COVID era and the COVID vaccination. The trust has shaken a little bit among the public. So what is the advice that to give to increase that trust, and how to overcome not the hesitancy of the people, as Riley was saying, the hesitancy of the healthcare worker to advise for more vaccination. So if you have any advice on that, thank you.
Yeah, that's a great question. Well, let's start with the WHO point of view. So how do we overcome, because this is a huge problem for the WHO, trying to get people to trust vaccines, but also to use community and primary health care workers to advocate for it?
Yes, exactly. Very valid question. Right information from the right organization and the trusted government, hopefully trusted government, is the most important one. However, especially for older people, there is internal ageism, meaning I'm too old to do this. It doesn't matter. There is no prevention for me. I'm too old. That requires a huge change of the mindset of older people themselves and society. How do you see it, older people? Older people is a value asset of society, and there is a prevention available. That needs to be really accumulated and educated, and the self-awareness and the self-motivation, ownership of the health. And prevention is available for older people. So WHO has a really good tool, so-called integrated care for older people, ICOP, that really support healthcare workers how to talk to older people, how to understand their diverse needs, and including prevention and promotion. Thank you.
Can I just ask you, Yuka, because Riley was saying that there would be value in having sort of pharmacists, local pharmacists advocating for vaccines. Can we bring in more people into giving that information and that awareness?
Exactly. So the community, usually the community has a trusted partner for the population. Community leaders, religious leaders, pharmacists. Actually, even in high-income country, I'm living in Switzerland, pharmacist is the one who knows all the medication history of myself. And then she told me, but you are missing this medication. You don't need to continue. And I was surprised. That was not GP, actually pharmacist. Right? So the bringing different stakeholders, especially at the community-based, is a key to work on it.
Thank you. Yes, Vernon.
Yeah, I would just like to add that, trust is something that you have to take a long time to build, and it can be destroyed in an instant. And you have to take a long time to build it over a whole wide variety of issues. So if vaccinations are the issue, you can't just go and ram through the message and build trust just simply on vaccinations. I mentioned earlier about, us using befrienders and grassroots leaders to reach out to the elderly. And that's because these individuals have built trust over many years, working with the elderly on somewhat, sometimes seemingly mundane tasks, like helping them with their groceries, being there to be a person to listen to, whatever issues that they might have, and so on. And once they've built those trusts, then we partner with them to bring in the vaccine message, and that vaccine message will be a lot more receptive than someone who they do not yet know. To bring back the message. And we can work similarly with, primary care partners that, might have already been treating them from various ailments for decades and have built that level of trust as well. Then we bring in the vaccine message. So I think if we can work through trusted partners, that would be a lot more effective. Thanks.
Yes, go ahead, Lottie.
I fully agree on the comments for the pharmacists playing a bigger role. We've also seen research that when the pharmacist is like the first sort of hub to go to, not only does it help elderly people, as you've heard, but also working age adults. They have wider opening hours. They're easy to get to. You don't need an appointment. Trying to get a GP appointment in the UK is in and of itself very hard, and that is the same in many other countries. Another element of this is when you bring pharmacists in, you can sort of start to reduce a little bit the health inequalities in access, because pharmacies tend to be more available to more people than GP practices are. So I think beyond what has been said, the role of pharmacy is still very much under exploited, to use that term. So yeah.
Thank you. Thank you very much indeed for the question. Any other questions from the audience? Yes, gentlemen.
Yes, thank you very much. My name is Tomáš Petras. I am a medical doctor from Slovakia, and I represent the Slovakia delegation as a youth delegate at this WHA. My question is a follow-up to the second part of my colleague's question about how to sort of elevate the responsibility of the primary care providers in terms of vaccination. So obviously during the panel you mentioned quite a lot that they play a huge role in the whole topic of today's panel. And my question is primarily focused on whether financial incentives for the GPs, for example, would be relevant. And if you do have any data or any information from, member states or some organizations that work on this agenda.
So the question is incentives for primary caregivers to build immunization into a schedule. Any thoughts on that, Lottie? Would that work?
Short answer, yes. Of course, we have to really think about our incentive design in all of this, and then who we sort of want to make sure that they are at the forefront and that they have enough incentive literally to sort of do this. So yes, that's true. I think the question is how to do this, because there's many things that we're requesting GPs to do. Not only this, so it's really a balancing act between all the things and what should we incentivize for whom. Like I said, pharmacies, I think we have quite some headroom there. We can do more. Also thinking about pharmacists, but also pharmacist technicians, I think they're called. So there's like multiple people within the pharmacy. We can also think about who do we really need to sort of have this conversation. And what I really liked about the Singapore example is like maybe it's even outside of the primary healthcare system. Maybe it's indeed working with people in the community, because I think that's really critical where that starts.
Riley, can I ask you, one of the problems is, and it's not just the UK, there are plenty of other countries where GPs and primary health caregivers are really stretched. I mean, you can barely get in to see a GP half the time. So how does it work if they're building in an extra layer of care that you have to have alongside your annual health screening or whatever?
I think if we look at both of your questions there, I think the answer is that, well, partially we need to take the pressure off of primary care when we can. So looking at nurses, looking at community health, pharmacists, what we can do to build capacity in other medical specialties that are able to have that conversation, as well as utilizing patient groups and those sort of informal accesses of information to at least have them coming to an appointment with a GP with their questions already pre-made, or enough awareness for them to be able to initiate and have that first step for shared decision making. I think as far as incentivizing and GPs, I would maybe suggest that instead of having it be tied to the delivery of a certain vaccination, that it's more of a consultation or like an action plan for vaccination. Just so that there is a more holistic approach. Otherwise, likely you'll get GPs going through the vaccines that are easiest to sell to a patient rather than the ones that they need the most. That would be my one suggestion to it.
And perhaps just a final question from me, Yuka. We saw the example from Singapore. Singapore is very well organised. It's got the infrastructure in place. It's got the resources. When we talk about low and middle income countries, realistically, how are we going to build an immunisation schedule into that?
Yes. Thank you so much for the question. I actually see the good example from the low and middle income countries. Having said that, using the age-friendly environment and bringing the community stakeholder is the key to bring the vaccination to the older people, including other populations. And there is already mechanism exist. Community healthcare worker do the home visit, primarily checking baby and pregnant women. But she or he can extend to the adults and older people. And most of the time, actually, older people taking care of the grandchildren and adults are working outside. So that is opportunity, actually, community healthcare worker encourage and educate these older people to be vaccinated. Or other cases, there is older people associations. Basically, older people themselves actually raise awareness and they listen to each other because they are folks, like-minded folks. And they are the ones who promote vaccination is important. Let's go together to the vaccination campaign. So that is possible. And I just wanted to highlight one thing around when we talk about life course vaccination, somehow we tend to see A population versus B population, right? Young population versus older population. But there is evidence intergenerational activities brings actually more benefit. So the younger children or younger adults actually supporting older people, and older people actually taking care of the children. So why don't you use a vaccination as an opportunity to vaccinate both? So there is an innovative actually approach, not only thinking about per population or per diseases, but rather more for the intergenerational approach. Thank you.
Thank you. Thank you very much indeed. I want to thank our panelists. Thank you for your questions. I think what you have shown is that obviously there are still challenges in reshaping healthcare systems to fully integrate adult immunisation, but the pathway is there. So many thanks for your expertise. It is my pleasure now to introduce Gregor Snedden, the Secretary General of the IFA, to make some closing remarks.
Thank you. Thank you. And the cost of inaction, and governments as partners in innovation and health promotion and inclusion of older persons in the solutions that are being created with them. A broad societal impact beyond our health systems, stakeholder engagement and age-friendly environments and community-based care. Well, you know, it seems to me and maybe to you that the systems we've built in global health policy are not neutral. They cost lives, they cost function, and they cost systems their sustainability. Infectious disease, NCDs, healthy aging, health system resilience. These are not parallel tracks. They're the same track, experienced by the same people in the same bodies, all at the same time. And nowhere is the cost of fragmentation more visible than in adult immunization. A vaccine-preventable respiratory infection in an older adult with a cardiovascular disease or diabetes does not stay a respiratory event. It becomes a hospitalization, a rehabilitation episode, a loss of independence and a transition to long-term care, a caregiver crisis, a workforce absence, a fiscal burden, and each preventable and each systemic. And the evidence is clear. The frameworks, as we heard today, they exist. As of the General Assembly's formal adoption just this past December, the world has a new political declaration on NCDs and mental health, committing member states to accelerated, integrated, equity-grounded action. And that declaration represents a hard-won momentum. But the question before us now here at the end of a long week at the World Health Assembly in these closing minutes is, 8 months on, are we executing on that commitment? Because declarations do not prevent hospitalizations. Implementation does. And implementation requires us to be honest about what is currently missing, including how we define success. The IFA constituency statement to this assembly speaks directly to this point and addressing the framing of premature mortality on deaths before the age of 70. In a world where people routinely live into their 80s, 90s, and beyond, where the fastest growing demographic globally is people over the age of 80, defining premature death at 70, that really does not reflect a demographic reality. It implies, however, unintentionally, that lives lived beyond that threshold are somehow less urgent, less worthy of prevention, less deserving of the full weight of our health systems. Language is not neutral, and targets are not neutral. And when we set a ceiling on whose deaths count as preventable, we set a ceiling on whose health we are willing to invest in. No? So I think the WHO and member states must re-examine these targets and the data systems that underpin them to reflect the full contribution of older persons and to drive down NCD-related death and disability across all ages, not up to some arbitrary threshold. And this matters directly for adult immunization. If our accountability framework stops counting at 70, then they will stop investing at 70. And that is precisely where the burden of vaccine preventable disease, frailty, and functional decline is most concentrated. Adult immunization, as we've heard, must be embedded structurally, not aspirationally, into chronic disease pathways, primary care reform, frailty prevention, rehabilitation, and long-term care planning, not as an add-on, as infrastructure, alongside routine screening, brain health, cardiovascular care, and early intervention, all of it oriented toward maintaining function, independence, and participation across the life course. And this also requires age disaggregated data, geriatric competencies in the health workforce, the genuine alignment between NCD policy and long-term care, dementia, disability, and social protection systems. Continuity of care is not a luxury, it's the architecture that prevents avoidable decline. And equity demands more than just availability. Meeting people where they are, accounting for mobility, digital exclusion, fragmented services, and eroded trust is not a handy program slogan. It's a governance obligation and the most critical lever we have to ensure uptake and participation. The 2030 deadline for SDG target 3.4, reducing premature deaths from NCDs by 1/3 by 2030, is not distant. We're only 5 years away and behind on that trajectory, and operating in a global environment, as we all know, of constrained fiscal space. And so I would argue that this is not a moment for aspirational language. It's the moment for coherent systems, accountable governance, and the political will to treat prevention as foundational, not residual. And civil society must be meaningfully engaged in implementation, not consulted after decisions are made. At the IFA, our position is unambiguous. Healthy aging is about preserving functional ability, autonomy, dignity, and participation. Investment in NCD prevention and community-based care is not a cost. It is a driver of health and economic resilience. The demographic transition, it's not coming, it's here. And prevention is not optional. It's the infrastructure on which everything else depends. And every life, at every age, deserves to be counted. Thank you.
Gregor, thank you. Thank you very much indeed for that. We very much hope you found the session informative. We invite you to continue the conversation. We have some refreshment and lunch for you in the next, just outside this room. We would love to continue the conversation with your thoughts and insights. But before we leave, please give all my speakers today a last round of applause. Thank you. Thank you.